So we were talking about ACL rehabilitation. So here I would like to talk about, already I've discussed about what need to be done, and then graft type. It's a purely a surgeon choice. Whether are they going to harvest quadriceps tendon or the patellar tendon graft or hamstrings, especially the STG, semitendinosus and gracilis, or the either they are going to do along with the meniscal repair or excising, or is there any bone brioche chondroplasty, or is there any previous lesions? So I'm going to talk about concept of ACL rehabilitations. So immobilization to accelerated rehab to a customized rehab. So as we seen in the previous slides, the customized rehab based on especially the graft type and then the surgical procedure, either are they going to do ACL reconstructions alone with any mentioned graft, or the ACL is going to be performed along with the meniscal repair or a meniscectomy. So also they look for, is there any structures other than the ACL as involved arthroscopically. So the pre-operative, it's very essential for following patients who diagnosed ACL insufficiency. So the critical part of rehab program is like, basically we encourage the patient to do a 3 weeks pre-operative program. Mainly it focuses on reduce the swelling and inflammations, and we try to restore the normal range of movement, especially the extension. If a patient presents to you with the extension deficit, it's important to restore the extensions before they go in for a surgery. And initially the patient needs to be educated with isometric exercises like pressing the knee down, and maybe the patient comes to you with the gait disturbances, because so if they have a feeling of giving away, so they either might use walker, or they come along with the knee brace, or they use the walker, so they don't distribute the body weight into the leg. So it's our primary responsibility to normalize the gait, like, so from the heel strike to foot flat mid stance, and then heel off, and then toe off, and then swing through phase. So we have to normalize the gait, and then so what we focus really on early preoperative rehabilitations. So in order to reduce the pain and swelling, we educate the patient to do cryotherapy, and then we we do neuromuscular electrical stimulations to activate the muscle, facilitate the muscle function, as well as to retain the strength. And the bracing is especially to relieve the pain, because they might have a pain when they have a heel strike. So the bracing is to relieve pain and protections, because if they have a giving away feeling, so the brace will protect, restrict the, or prevent the anterior translations. And then if you try to encourage the weight bearing, immediate weight bearing following surgery with the brace and then associated procedure. If patient is not comfortable in walking without walker, so you may use the walker on the first POD. I mean, you can encourage during the pre-rehabilitation process. So we focus, since it's being considered the pre-operative rehabilitations for 3 weeks. The first week you can expect the patient to do the 90-degree flexions, and then second week at least 110 up to 10-degree flexions, and then 6 weeks full range of movements. So you need to encourage either the OKC, open kinetic chain versus closed kinetics. So the intermediate phase, 6 to 12 weeks, still protective of graft. Almost we'll be able to achieve full range of movements, and then no swelling at rest. Walking without non-weight bearing, weight bearing walking, and patients might wean off from the brace, and then we'll try to increase the progressive loading on weight bearing activities. Also, we teach all the balance exercises, coordinations, proprioceptive training, along with the neuromuscular control drills. Along with, so what are the exercises that we're going to describe? Either ask squats, lunges, step down, clamps. Also we have to focus on hip musculatures, because as we seen in the earlier side, always you have to look at the joint proximal as well as distal. So the clamps which will strengthen the glutes medius, especially the abductors, and then lateral band walks. So the recent evidence says that the lateral band walk has a maximum volume contractions at a different level. So most of the people, we encourage the patient to walk with the band just above the knee, or at the ankle, or at the foot. So at the foot, like, it has got more evident that the hip abductor muscles works efficiently than other two positions. And then always we have to make a stability progressions, and then bridge to strengthen the muscles, and then load and range progressions. And advanced phase is what are the prerequisites that we look for? The patient should have attained the complete range of movement, pain free. They must have improved the strength, power, and endurance, high level neuromuscular control. And once the patients get the clearance from the sports physicians, you may encourage a sports specific drill. And then also we have to improve the psychological aspects, like, they have to gain the confidence. We have to make the players to be confident on the operated side. So as with the exercises, strength and endurance program, running drills, and then landing drills. In that PSCL, so in Center of Sports Science, so we have seen a lot of patients from plinth to performance. So surgeons do a surgery, and then 10th POD they come here to see us for suture removal, and then we teach them a set of exercises, includes patellar mobilizations, isometric co-contractions, active SLR in 2 or 3 planes, and the patients with the ACL reconstructions without meniscal repair. We encourage yearly range of movement at 10th POD. There is a debate still going on. Most of the hospitals in the other side, they initiate yearly range of movement, so initiating range of movement at the knee after 10 days will have more efficacy, because during the 10 days the patients will gain more confidence, as we discussed in the early slides. They develop more confidence, and then they'll be able to perform very, very well. So how do we rehabilitate PCL, posterior cruciate ligament? So before that, we look into the functions of PCL. It's a primary restraint to posterior translation of tibia. Also, it acting as a secondary restraint to external rotations, and it will increase the contact pressures in patellofemoral and mediotibio-femoral compartments after sectioning of PCL. So posterior cruciate ligament during exercises, when you do a closed kinetic knee flexions, so the PCL will go for higher posterior shear force with a high flexion angle. When you are performing open kinetic chain knee flexions, there remains high posterior shear force throughout the entire range of movement. So when you do any extension in open kinematic chain exercises, there is a minimal or no stress on the PCL from 60 to 0 degree. Maximum the passive range of movement generate minimal force in PCL, and co-contraction of quadriceps, hamstrings, and gastrocnemius can unload all the cruciate ligaments. And the gastrocnemius contractions stabilize the PCL, posterior cruciate ligament. So of course, when you talk about posterior cruciate ligament, the posterior tears in PCL are more common than the ACL. So isolated grade 1 and 2 PCL injuries potential for good clinical outcomes following non-operative treatment. So ruptured, even though it's a ruptured, complete rupture, it heals well, but may be elongated position. So it takes the load from hamstrings, especially gravity and the dynamic load, and then there will be a greater force generated in the PCL than the ACL. So, and when to brace when you have a patient with a PCL injury. So if it is isolated grade 1 2 injuries, grade 1 and 2 less than 10 mm, and then combined with posterolateral corner or multi-ligament injury, and even after post-operative management and during rest and functional movement, so the patient should wear the brace. So what are the bracing recommendations? So if you talk about acute period, it's from 0 to 6 weeks, and then at all times except to shower and then change clothes, remove standing or prone positions, so not in supine positions. Subacute, it's last from 7 to 12 weeks, and then dynamic brace, you can increase the limited range of movement at all times except to shower and then changing clothes. So the dynamic brace again 4 to 6 minutes, and then during functional activities. So summary of rehabilitation guidelines here. So more conservative than ACL rehabilitations, and then it has got yearly controlled passive range of movement, yearly weight bearing, and then graded muscle strengthening the protected range, controlled CPM for about 0 to 60 degree at the initial phase, and possibly the open kinetic chain flexion exercises can be avoided. So ask the patient to discontinue the crutches, and along with that you can encourage the patient to do cryotherapy as well as electrical stimulations. When you talk about meniscus and cartilage, so the functions of meniscus, it acts like a shock absorber, it acts as a joint lubrication and nutrient distributions. Also it has got both sensory as well as proprioceptive function. The meniscus is increase the congruency and joint stability, and the meniscus allows movement of bones relative to a joint as relative to each other, acting as a shock to prevent undue forward gliding, facilitating rolling forward of the lateral femoral condyle as the femur rotates medially at the end of extension. It improved weight distributions, and also it protects the joint margin. So there are some non-operative options for meniscus tear, but the meniscus tear it should be asymptomatic, especially in older individuals. And if it is a partial thickness tear, minor tear at the inner margin, stable horizontal or short oblique tear should be less than 5 mm. Tears in arthritic knees without mechanical symptoms can be managed non-operatively. So when we talk about rehabilitation following meniscal repair, the meniscal injury patterns are usually 60 to 82% in acute ACL tear, up to 96% in chronic ACL tear. So the lateral meniscus more commonly injured along with the ACL in acute injury, whereas the medial meniscus more commonly involved in isolated and degenerative meniscal tears. Challenges in rehab: yes, it takes long time to rehabilitate, need for restricted weight bearing and range of movement, a risk of re-tear and subsequent surgery up to 30%. So the rationale of rehabilitation here is the better healing rates of meniscal repairs with associated ACL reconstructions. Condition of a meniscus influence knee stability, especially anteroposterior and rotational. And one question, can we apply rehabilitation principles of isolated meniscal repair? That's my question here. For a standard rehab protocol, the ideal patients, time based versus criteria based, customized versus standardized protocol, ACL bias versus meniscus bias.